Any of the information and resources that we talk about today will be available online via either the Cracks in the Ice or NCRED websites, and we're also very happy to send around a copy of the slides as well. So I'd also like to acknowledge and pay my respects to the traditional custodians of the land on which we're meeting. I'm on the land of the Gadigal people of the Eora Nation, home to the beautiful Gadi trees. And I'd also like to pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. So this is just a breakdown of today's webinar. I'm going to start by talking through the effects of methamphetamine and then go into some of the ways to reduce or limit those effects through harm reduction strategies. I'm then going to hand it over to my colleague Dora to talk through practical skills for crisis situations and treatment options. And then finally, the other Stephanie will go through some referral and support options available. So what is methamphetamine and what are its effects? So apologies if you already know some of this information. I tried to sort of cover a wide range of knowledge, but methamphetamine belongs to a group of drugs called amphetamine-type stimulants, and that covers a large range of drugs, including the illegal ones like amphetamine and methamphetamine, but also pharmaceutical drugs like dexamphetamine, the ADHD medication. And these drugs are stimulants, and that means that they speed up the central nervous system, making people feel really alert and excited. Now, methamphetamine itself comes in three forms: crystal or ice, as it's sometimes called, base and speed. And these forms vary in purity and potency, with crystal often being the more pure form. And currently in Australia, crystal methamphetamine is the most current most common form currently being used. And it has been for the last decade or so. And since we saw that increase in the use of crystal methamphetamine, we've also seen a rise in methamphetamine-related harms. And so this is increased helpline calls, hospital admissions, and even drug-related deaths. Now, when we're talking about drugs and substances, it's important to remember that the effects caused by the use of any substance, so whether it's caffeine, alcohol, or illegal drugs, it can sit anywhere on the spectrum from beneficial to problematic use, including harmful use and substance dependence. And substance use may begin at one point on this spectrum and move to another point, or may remain stable, and it can move either gradually or rapidly. So I guess the thing is, not everyone who uses drugs will develop a problem, and some people may only ever use drugs in recreational settings. When we look at why people use stimulant drugs, there usually isn't just one single reason. It's often a lot of things in combination. For example, they might try it because they want to fit in or out of boredom and escapism. They might also use stimulant drugs to forget or cope with problems like unemployment or unstable housing, if they're feeling stressed or having some sort of difficulties. Also, people may use stimulant drugs to manage mental health issues, like if they're feeling really depressed or they're in a low mood. And another way sometimes people also use stimulant drugs is to enhance performance. So if they're really working a long shift, then they want to work longer hours, or if they want to enhance sexual experiences. And sometimes people just use stimulants because they like the way it makes them feel. But regardless of why someone starts to use, there is a risk of it becoming a problem. And when we look at what the protective factors and risk factors associated with methamphetamine use and dependence, we know that there's a close relationship between health outcomes and a person's living, working, and social situations. So there are protective factors and risk factors that can really influence whether someone starts using drugs. For example, family and peers can be a protective factor if you have a strong family connection. On the other hand, they can also be a risk factor. Sometimes people who use methamphetamine often have friends or partners who use the same drugs and frequently spend time in places where drugs are accessible and normalized, such as parties and nightclubs. But also there are a range of other factors, and this includes education. So we know that the level of education a person has often affects their employment opportunities, and that lower levels of education and unemployment can be risk factors associated with use. And there's a number of other factors, including exposure to trauma as well as social determinants of health. So it's really important to understand that drug use is influenced by a lot of factors and a lot of reasons. And so when someone is seeking help or treatment, it's key to look at those underlying reasons. Now, methamphetamine has a number of effects, both short-term and long-term. And so this is just a figure taken from Cracks in the Ice. And the effects that someone might feel will depend on how much is taken, the purity of the drug. So as I said, crystal methamphetamine is often more pure than the other forms based on speed. How the person takes the drug, so whether they inject it or smoke it, and whether they're taking any other drugs, like, for example, drinking alcohol at the same time. That also will depend on the person's own physical and mental health. And we know that if people are using heavily, that is associated with more serious long-term effects. And I'll talk about that a bit later. But firstly, I just want to talk a little bit about methamphetamine and the brain. So in the brain, neurons communicate to each other all the time through releasing chemicals called neurotransmitters. But what methamphetamine does is it causes the artificial release of three really important neurotransmitters: dopamine, serotonin, and noradrenaline. And they're all involved in a lot of processes, but they all overlap where it comes to mood and cognition. And one thing to note with the release of dopamine is that that's associated with that feeling of pleasure and reward, and that's what encourages people to do that activity again. And when we look at how much dopamine is released by methamphetamine, it's massive compared to everyday activities like food. For example, when you eat chocolate, you're going to get a bit of a dopamine release. When you have sex, and even when you drink your morning coffee. And when methamphetamine is released, you can see in that big pink line, it's a huge spike compared to those other everyday things. And also even compared to other drugs like cocaine in that navy blue and nicotine in the green. And that's why people often report saying that they feel a rush or a lot of euphoria when they've used methamphetamine. But this massive release of dopamine and the other transmitters can overload the system, and it does come at a cost to the body. And that's why some people can't sleep for a few days after they've taken methamphetamine. And what methamphetamine also does is it stops the brain from reabsorbing these chemicals, which then lowers their overall supply. And that's why people feel low and irritable for up to 2 to 3 days after taking the drug. Looking at the body, the short-term effects of methamphetamine include things like increased energy, talkativeness, increased sexual drive, but there's also some unpleasant things that can happen, including increased heart rate and body temperature, dehydration, paranoid thoughts and mood swings. And some people can exhibit aggressive behaviour if they're using the drug frequently. And there's a lot of research going on at the moment trying to understand the relationship between methamphetamine use and aggression, as it doesn't seem particularly clear-cut. And as I mentioned, the effects of methamphetamine also depend on what other drugs someone has taken. So the more drugs a person has taken or is affected by at a time, the more chance there is of something going wrong. So for example, taking crystal methamphetamine and drinking alcohol, and alcohol is a depressant type drug, can lead to heart problems, psychosis, and increase the risk of overdose. And there's also risk when combining crystal methamphetamine with other stimulant drugs like ecstasy and even medications. If methamphetamine is used over a long period of time and heavily, it can result in a number of long-term effects on both the brain and body. And a few of these include dependence, so not being able to function without the drug. Stroke, this can happen regardless of age. It happens in both young people and older people. And there's also risk of damage to important organs like the heart, lungs, and kidney. And there's also exhaustion and malnutrition, and it's been linked to overdose and accidental injury. Now, people using methamphetamine also experience mental health symptoms, and there's been a lot of evidence linking methamphetamine use and mental health recently. And these mental health symptoms can happen while using the drug or while the drug is wearing off. And they can last a few days or a few weeks. And this graph here just summarizes some of the short and long-term effects that can happen. But it's important to realize that for some people, these mental health symptoms persist and develop into mental health disorders in their own right. For example, depression, anxiety, and psychosis. And when that happens, it can lead to what's called co-occurring health conditions. And so this is where a person has one or more medical or health conditions at the same time. And what we're talking about here is where people have a methamphetamine use disorder and a mental health disorder. And that makes it quite tricky because these conditions often interact with each other and can even make each other worse. And so we know that for people who have a co-occurring methamphetamine use disorder and mental health disorder, they generally experience poorer overall health and well-being compared to if they just had one of those disorders. And that infographic here just lists some of those harms associated with having co-occurring conditions, such as poorer overall physical health, increased risk of self-harm and suicide, and increased risk of homelessness. So it's important for people who are experiencing co-occurring conditions, or as it's sometimes called comorbidity, that they receive treatment for both conditions. In terms of signs that someone may be using crystal methamphetamine, these can include someone who has increased energy, particularly if it's followed by periods of exhaustion or fatigue or insomnia. If they have a reduced appetite or just changes to their eating patterns and complaints of stomach cramps. It's also not unusual to hear if someone's having headaches or dizziness, they're feeling really irritable and moody, and that all ties back to those neurotransmitters being released in the brain. Also, another sign can be if they're, having problems with money or friends or relationships. These can all be indicators that a person may be using methamphetamine. But, it's important to remember that methamphetamine will affect different people in different ways. So just because these signs are present doesn't necessarily mean someone is using. And it's always good to try and have a conversation. Now, if a person's methamphetamine use is becoming a problem, some of the warning signs can be when that person starts to say that they're worried about their use, that they want to stop or cut down, but just can't. You might notice that they start using larger amounts of the drug, or they're using over a longer period of time. Some of the signs can be that they've stopped or reduced their social activities. So they're sort of missing events or not going to their regular sports catch-ups, or they're forgetting or not carrying out routine responsibilities like going to work and school. And their drug use often will affect their relationship with their families, friends, and colleagues, as they will often prioritize drugs over those relationships. And so these can all kind of be signs that someone may have developed a problem with their methamphetamine use, and it might be time to start a conversation about seeking support. So now I'm just going to talk a little bit around harm reduction. So harm reduction is just focused on respecting people's rights. So some people who use crystal methamphetamine can't or don't want to stop. For example, recreational methamphetamine users who haven't developed a problem with their methamphetamine use may just want to use methamphetamine and need to know how to do it in the way that's most safe for them and reduce those risks. And so what harm reduction is, it's about seeing the people as a whole person and treating them without any sort of judgment or discrimination, or requiring that they stop using drugs as a precondition of support. And there's a lot of evidence that harm reduction practices are practical and safe and cost effective in many settings. So some specific harm reduction strategies that people who use methamphetamine can use can do include staying hydrated, so frequently taking small sips of water, taking time out to rest if needed, and this will help to balance out the increase in heart rate and blood pressure and temperature. Also avoiding the use of other drugs at the same time, so not drinking alcohol at the same time or caffeine or using other drugs, because that can all lead to unpredictable side effects. And it's important to be aware that methamphetamine is an illegal substance, so it can be mixed with anything before it's sold. So whether that's other drugs like ketamine or opiates or simply glucose. And these impurities can alter the effects of the drug. So if people are using it and they notice something or they don't feel right, it's important for them to seek help. And this is why there's been a lot of discussion around drug checking, or it's sometimes called pill testing, because this can help tell people what exactly is in the drug that they're about to use. Some other harm reduction principles include safe sex practices. So as methamphetamine can lower those inhibitions and increase sexual drive, it's really important for people to be prepared. And this includes sort of setting boundaries and having protection, but also, taking medications, for example, antiretrovirals. But there's a lot of specific information around that, particularly for people who are interested in chemsex. So I would encourage you to check out some of the resources that are available on both Cracks in the Ice and the Insight Australia websites. Other harm reduction principles include sort of being aware and encouraging safe injecting practices. Injecting can increase the risk of bloodborne viruses, including Hep C and HIV, but also infections at the injection site and vein damage. And lastly, just knowing those signs of overdose. If someone's having chest pain, having difficulty breathing, confusion, disorientation, being flushed, hot and sweaty, those are all signs that something might be going wrong and it's important to seek help. And as I said, there's a lot of evidence-based information. This is just a very quick summary. So if harm reduction is something that is interested in and you want to know more about the resources available, please check out the websites. And the last little bit that I'm going to talk about is just how communities can support young people who are using methamphetamine. So in terms of what families can do, we've just got some tips here which are based on evidence around what we know works and what doesn't work. And so it's important for families and communities to be supportive. So knowing what's going on in the life of a young person, what's worrying them, are they feeling lonely, is something going wrong at school? It's also really important for families and community members to be good role models. Your thinking and your behaviour will influence a young person's thinking and behaviour. So, if you set a good example of how to deal with problems, or stresses without using alcohol or drugs, that can help protect young people. It's also really helpful to build and maintain strong and positive family relationships and having that open line of communication. Encouraging and supporting the learning of young people is also valuable because we know that education can help protect against drug-related harms. It's also important to think about reducing the availability of alcohol and drugs, particularly in the home setting, and family members shouldn't be providing teenagers with alcohol or drugs. We also know that there's evidence about encouraging community activity, whether it's sports, whether it's a musical instrument or cultural activities. These can all help create a connection between people, reduce boredom, and just improve the health and confidence in young people. And the last one I want to talk about is just that it's important to provide them with evidence-based messages about drugs. So young people might not necessarily know the harms or dangers associated with drugs, or they might think that everything they hear or see online on TikTok is accurate, but in reality, it's actually quite sensationalized and definitely not based on facts most of the time. So it's really important to make sure they know the evidence or where to go to find evidence-based information. If you're worried or you just want to start a conversation with a young person around drugs, there are some sort of tips that are available. And these are, talking thinking firstly about what you know about crystal methamphetamine, gathering evidence-based information about what it is and what its effects, and have a clear idea of what it is that concerns you about crystal methamphetamine. And then you want to kind of arrange a suitable time to talk where you know you'll have some privacy and you won't be interrupted. So sometimes parents say, in the car when they're driving kids to school is the best time. But it'll all depend on what works for you and your family situation. But also ask them what they know about crystal methamphetamine. Don't sort of assume that they about their knowledge, and just try to make the conversation relaxed and give the person the chance to express their views. And it's important to try and not be too judgmental or tell them what to do. So particularly if they're having a hard time, that can make it harder for the young person. So just, might need to sit back a little bit and just listen and express your concerns in a supportive manner. And it's also just important to let them know that you care about them. People are likely to listen and engage in a conversation if they feel valued and respected. And just being trustworthy and supportive so that they know that they can rely on you, and knowing that anything that you talk about is confidential, just between the two of you. And, just let them know that you're always available to talk in the future. So these are some great tips. Obviously, not every time you start a conversation may go well, but it's important just to keep trying, just to keep that door of communication open. And more generally, we can all support young people by trying to understand the reasons they are using drugs. As we've talked about, there's a lot of reasons and factors. So it's important to think and address them. For example, is it because they're stressed? Is there something else that we can suggest as a way to reduce their stress? It's also really important just to encourage those who are worried or experiencing difficulties with their methamphetamine use to seek support. So it's never too early or too late to seek help. If someone is feeling like their use of methamphetamine is getting out of control, or they've started noticing problems or unintended consequences, encourage them to seek support. And just again, connection with family, community and culture is so important. It can help reduce use and encourage people to seek help. So avoid isolating people who use methamphetamine, and try and just keep them connected in a way that you and other community members or family members feel comfortable with. And I just lastly want to finish my part of the talk by talking about stigma. So there's a lot of stigma around methamphetamine use. We know from my research that around 40 to 60% of Australians hold stigmatising views about methamphetamine. For example, they will say, I won't associate people with people who use crystal methamphetamine. And this stigma is actually quite harmful because it prevents people from seeking help, and people will put off seeking help and support sometimes for years, and by then those long-term effects of methamphetamine are really starting to take into effect. So one quite simple way that we can, as a starting point to reduce stigma, is think about how we talk about it. Stigma is a lot more than just language. But language is really important. And when we focus on people rather than their use of alcohol and other drugs, and when we choose words that are non-judgmental and inclusive, we can actually reduce the impact of stigma and encourage help seeking. So I just wanted to flag that there are some great guides available. The one on the left, The Power of Words, was developed by the Alcohol and Drug Foundation. And both of these guides have been developed with people with lived experience. So they're just really helpful, and it's something that we can all do when we're talking about it. I'm now going to hand over to my amazing colleague, Dora, to talk through some practical skills for crisis intervention.
Thanks so much, Steph. Thanks for having me, everyone. My name's Dora, and I'm coming to you from Darrawal country, my hometown of Wollongong on the south coast of New South Wales. I've only got about 10 minutes to kind of breeze through this stuff, and I just want to name up front, probably spend a whole day or even a couple of days really delving deep into this subject. And So I'll give a super brief overview on just a couple of what I think are probably some important key points to kind of explain sort of working with crisis within the context of a person using methamphetamine. I'm going to use this model, which is from the New South Wales Department of Health, which conceptualises a crisis as being a 5-phase process. And for any of you who are working with individuals in a frontline perspective, I dare say it probably resonates in that there's, we start with a triggering event, move through escalation, there's a peak of a crisis, and after that we can sort of start that downward journey back to recovery and post-recovery. And I'm going to try and put a bit of a neurochemical kind of spin on. So starting with phase one, we're talking about the triggering event. And a triggering event is any event that elicits the elevated or distressed reaction. And it's important to sort of step outside of ourselves here, because things sometimes, that we perceive as being a valid or reasonable trigger, it might not be the case for the person going through it. So it's any event that the person perceives as being upsetting, threatening, or frustrating. I've just put for a bit of, further reading for anybody who's interested. One of the most useful or handy models of understanding this type of thing is the hand model of the brain by Daniel Siegel. There's heaps of resources online about that. But basically, in a nutshell, a very brief nutshell, you can conceptualize the brain as having 3 major kind of parts, and that's the reptilian brain, or like the brain stem. So that was the first part of the brain to evolve. We've got the limbic brain, so the midbrain, which is the emotional brain. It's responsible for hormone regulation and a whole bunch of that sort of thing. And then we've got the neocortex, which is the top of the brain. It doesn't develop in young people until somewhere in their mid-20s is generally, I think it varies by gender, by sex and age. So women thought to develop their prefrontal cortex first. Young men are thought it's not until their sort of mid-20s where there's a fully functioning prefrontal cortex there, or neocortex, called in this diagram. But that's the part of the brain that's responsible for higher order thinking. And what, we'll just go to the next slide if that's the case. Thanks. Basically, what's happening when a person is moving, so they've been triggered and they start moving into phase 2, that escalation stage, is that the prefrontal cortex of the brain shuts down. And that's, most of us have probably heard of fight or flight. And, basically that's the stress response of the brain. Now, what basically happens when the brain goes into fight or flight, the thinking part, the rational decision-making part of the brain shuts down, the emotional part of the brain sends all of these warning hormones to the reptilian brain, which doesn't think, that acts on impulse. And so when we're talking with, we're working with a person in crisis, we're often working with somebody who isn't thinking with their frontal lobe, their thinking executive function brain, but thinking impulsively and with very sort of primal or elementary brain process. And I guess that makes sense, because if you're, faced with a bear, you don't want your prefrontal cortex rationalizing a decision. You just need to act. And crucially, though, there's some hormones involved in that, like adrenaline. Cortisol is another one, which is the stress hormone, but crucially adrenaline. And I want to just add in here about methamphetamine. So Stephanie just talked about some of the neurochemistry that comes into the use of meth, and talked about dopamine and noradrenaline and serotonin and things like that. Something that's sort of emerging out of literature now is when a person uses methamphetamine, the dopamine, so that's the feel-good reward pathway, that's really strong. But alongside is a huge surge of adrenaline, and this exists in meth. And that's why if you're working with somebody who's using methamphetamine, they might come across as a bit edgy or a little bit, flighty or fighty even, and that sort of aggressive sort of style thing. And that's because there's an abnormally large surge of adrenaline. And so with adrenaline, though, that naturally triggers a fight or flight in the brain. And so we're talking about a person who is triggered by something, perhaps really quite easily, is already, because of methamphetamine use, predisposed. Thank you for someone saying I keep coming out. Sorry, thank you. Please let me know if it continues to be a problem. But yeah, if somebody is using meth and they're already predisposed to a very simple trigger, a really simple, like reflexive fight or flight because of the high prevalence of adrenaline. But then something triggers and it triggers it even more, so a person can go into a full-blown crisis fairly easily and go sort of fast up the escalation, peak quite quickly. Can we have the next slide, please? In that phase, if you're noticing that a person is escalating, I'm really sorry. I've had so many problems with the headset, and when we tested it, it was working okay. Thank you for that, Kate. If we can de-escalate during that escalation phase, because we're aware that somebody, and we have this knowledge in our brain, we can in our minds as workers, and we can say, okay, this person's, not thinking with their right brain, they're predisposed to a fight or flight. That's what they're going. They're feeling like they're in a threat situation. We could try to use some de-escalation techniques. And so this model, Lassie, listen actively, acknowledge the problem, separate from others, sit down, indicate possible options, and encourage the client to try these options. It's really difficult when somebody is coming at us as workers to try to be our best emotional selves, our most rational selves, because we're humans too. We also have, a fight or flight and stress hormones and things like that that come out. But I think in these sorts of settings, it's, trying to be responsible for our own behaviour and not be reactive, no matter what the person is actually saying to us, because it isn't, you that they're really attacking, even if it sort of seems like that. But validating a person's experience from their perspective and let them being heard is one of the most important things. And, providing a safe environment for yourself and others as far as possible. We'll just go to the next slide if that's okay, because I want to talk a little bit about, again, we could talk all day about this, but there's a model called trauma-informed care. And if anyone who's not aware of it, it's a fantastic way to, or it's a fantastic system to understand in terms of supporting something. There's a real emphasis on safety, trust, and providing choice. So if a person is in that fight or flight mode and their brain is shut down because they feel fundamentally unsafe, by trying to show ourselves as being a safe person within that moment can make a real difference. Obviously, when a person's in that space, reactions can be released indiscriminately. And if, we need to provide some space for a person to calm down, sorry. And as much as possible, try to be a calming and neutralizing influence, just to reduce that perception of threat, which is at this stage, like I said, very biochemical, happening in their brain, whether or not it represents a reality or not. As far as possible, by introducing yourself and your role and your name, acknowledging the person's feeling and treating them with respect, speaking calmly and clearly. If we're thinking about a person who's feeling extremely threatened, it's probably better not to bamboozle them with multiple people or fancy jargon and things like that. But building a sense of trust and self-identity, speaking calmly and clearly, maybe having one person as part of the team who's responding to that can also be really useful. If a person's yelling at you, to sort of lower your voice and respond. It can be our instinct or nature to try to match a person when they're coming at us and yelling, but by trying to sort of take a step back and lower your voice rather than raising it. But using also those I emotive statements. So I'd really like to help you get home safely tonight. Using their name, if you know it. Michael, I can see that you're having a really hard time with this, and I'd really love to help you get home tonight, or whatever the situation is. Let's go to the next slide. Thank you. Something else to be mindful in dealing with a crisis is your body language. So if a person's in fight or flight and they're coursing with adrenaline, they might actually notice subtleties in your behaviour that you're not even kind of aware of. So if you inadvertently smirk or react to something that the person said, that might sort of contribute to the escalation rather than the de-escalation. So trying to be really mindful of what you're presenting within that space is really important. Again, so we're trying to avoid being seen as a threat. We want to listen attentively, just turning your body to the side, so not being confrontational in the way that you're holding your body language, maintaining a safe distance, taking a step backwards to maintain a safe distance and give the person space. Be mindful of your facial expression and your palms, and holding open palms and an open body language to signify a willingness to listen. Let's go to the next slide, please. Um, after So methamphetamine, and crucially as well, has a really long half-life. So that means that that's how long it takes for half of the drug to be detectable in your bloodstream. So it's very long acting. So people are intoxicated or affected by methamphetamine for upwards of 10 hours. Half of the drug is still detectable in the bloodstream. That's also a part of how dependence forms. But it's important to sort of recognise that the person sitting with an abnormally high amount of cortisol and things like that in their bloodstream, well up to 10 hours and beyond, depending on how long they've been using. Obviously, we know a lot of people use methamphetamine in a binge, and so it might be multiple days of use. As a person sort of coming back down from the crisis, it can take anywhere from 1 hour to a couple of days for a person's prefrontal cortex to come fully online. So for their rational decision-making self to come back into the picture. And it's really important at that time that workers are given an opportunity to debrief because it can be rough. We just go to the next and then the last phase is post-recovery depression. So I think we could probably all relate to a scenario where maybe we've had a fight with somebody or we've had road rage or something like that's happened, and that's all of those brain chemical things are happening. Our prefrontal cortex shuts down. We're starting to act on impulse out of stress and adrenaline and things like that. And as our prefrontal cortex starts to come online, we have reflection, basically. And a person who's using methamphetamine may be at a higher risk of experiencing a post-recovery depression type episode, especially if it's accompanied by a withdrawal effect and their substance dependence. And so, at this point in time, it could be really important to screen for suicide and risk and safety plan if that's appropriate. And maybe this might be a better time to start supporting a client with a what's next kind of goal. But I'm sure we can all relate to those feelings of shame and guilt that come through. I'll just really touch on very super quickly around treatment options. So notwithstanding the fact that very much understand that in the Northern Territory is such a large space, access to appropriate psychological healthcare and alcohol and other drug support can be really limited. But from an evidence-based perspective, the good news is that there are therapies that do work for people who use methamphetamine when they are ready to seek treatment. I mean, Stephanie mentioned before around the treatment access gap. It's estimated to be between 7 and 13 years between the time a person first experiences harm from their methamphetamine use, so experiences a side effect or a psychological harm or something like that, when they get help. And as a country, I think that it would be a big problem to solve, and it's a matter of public health urgency, in my opinion. But the good news is that when help is available, there are therapies that are effective. So cognitive behavioural therapy, acceptance and commitment therapy, and contingency management are the three therapies that have the highest evidence base for methamphetamine. But again, there's so many variables that come into this around, readiness to change, social support, all the other sorts of things that, produce wellness in a person. Importantly, there are currently no drug treatments for methamphetamine use disorder or for methamphetamine withdrawal. However, NCCRED, where I work, we complete clinical trials and we're looking for drug treatments for these things. And that's including, we're looking into lisdexamfetamine, ketamine, naltrexone, bupropion therapies to try to help people moving through those times, because the discomfort of withdrawal can be a real risk factor for relapse. And, with a person who's wanting to make a change, but withdrawal so difficult for some people. The other thing to mention is that we have a couple of other resources to note here. So we've developed an app called the SCheck app. That's available now. It's on the App Store. Anyone can download it and use it. It's part of a research project at the moment, but it's free. Anyone can get it. It's got self-monitoring. It's got a use tracker and a mood tracker, and it's got a whole bunch of other questionnaires and screeners to help people just keep a track of how much meth they're using and how it's affecting them, just based on the idea that can lead a person to sort of seek help earlier. The other thing is that NCRED has developed an internet-based self-management program for methamphetamine, so cognitive behavioural therapy available online. It's coming soon. It's finished. The product's finished. I'm excited because I've worked a lot on this. It's coming soon. It'll be free online. It'll be released as part of a research project, and we're just following, getting that launched through ethics approval and things like that now. If you want to know more about that, please subscribe to our mailing list, because we'll be launching, we'll notify people when, for instance, the Impact ICBT product is available. But there's a whole range of other resources on the Cracks in the Ice website and on the NCRED website. Feel free, if anyone's sort of interested or wants to know more about any of those things, please feel free to drop me an email and I'd be happy to chat with you. Just to acknowledge, I think Stephanie and I both funded, but Cracks in the Ice and NCRED are both funded by DOPAC. And we will hand over to Stephanie Holmes to, and there's a question from Nikita Kearney, just